Hi everyone, my name is Tariq Al Sayed and I'm one of the imaging faculty at Cincinnati Children's Hospital. I will be doing echocardiogram case of the month with you this month, and this is my email, so please feel free to email me with any questions or with any feedback.
So this patient has a prenatal diagnosis of dextrocardia with a left superior vena cava and coarctation of the aorta. She was started on prostaglandin postnatally and was transferred to our hospital. In our hospital, she was sent to the OR on day of life 4 for coarctation repair via left thoracotomy. Without any further delay, let's go ahead and start looking at the images. So here we're doing a sweep from the subcostal coronal, and this is where many programs start their echocardiograms. So there are two schools of thoughts. Many programs start their echocardiogram by doing subcostal sweeps, and that delineates the anatomy really well, especially in newborns, while others will start from parasternal long axis views and then do the subcostal at the end with the hope of not to agitate the baby while putting the echo probe on the abdomen. But here we started from the subcostal, and as you can see here, the heart points to the right, making this a dextrocardia. And then looking at this ventricle here, this is the right ventricle. And then this is the left ventricle here. This is the pulmonary artery, and we see the aortic valve and the ascending aorta here. So I'm gonna let this play one more time. So you see the dextrocardia. You see the tricuspid valve here, the right ventricle, and then we see the left ventricle. I'm gonna stop it at the left ventricle as well. So we see the left ventricle here and the left ventricular outflow tract, which is this here. And then this is here looking from subcostal as well, and we're doing an agitated saline injection in the left arm. So as mentioned, this patient has a left superior vena cava, and on the color Doppler there was a concern that there is an unroofed coronary sinus. So we wanted to prove that, and to do that we did a bubble study by injecting agitated saline in the left hand IV. And the agitated saline, as you can see here, is coming through that left superior vena cava to the right atrium, and we don't see any bubbles in the left atrium, so that proves that there is no unroofed coronary sinus in this case. Now let's start looking at the aortic arch from the suprasternal notch here, and as you can see, this is a sweep through the aortic arch. You see the normal size of the ascending aorta and the transverse arch here, and then you see the area of the isthmus, which is very small, as you can see here. I'm gonna let it play one more time to look at that aortic isthmus. So if I stop it here, the aortic isthmus is this area here, and it is very hypoplastic, consistent with the diagnosis of coarctation of the aorta. Now in this clip here, we're looking at the size of the transverse arch, which was normal, and then putting color over the transverse arch and that area there, we see that there is a large ductus arteriosus, as you can see here, with right to left flow in systole, consistent with the diagnosis as well, and left to right in diastole, which is usually the case, as the systemic vascular resistance is higher than the pulmonary vascular resistance in most patients. Now looking at the arch branching here, and we attempted to view the arch branching multiple times, but the way we usually do it, we go to the start at the ascending aorta and sweep superiorly, and usually the first branch will go to the right, consistent with the right innominate artery that branches into a right common carotid artery and a right subclavian artery. And we couldn't see it very well in this patient. It was a difficult echo, and this is just another view here showing the ascending aorta, and as we follow the branching, it was thought to be normal branching. Now let's look at the echo report as it's read here. So the echo was read as dextrocardia with bilateral superior vena cava, a left aortic arch with normal branching, and the segment between the innominate artery and the left common carotid is elongated, with at least moderately hypoplastic aortic isthmus with posterior shelf. There was a large patent ductus arteriosus, and there was a bicommissural aortic valve with normal function and a qualitatively normal ventricular function. Now in the OR, the patient underwent left thoracotomy with an extended end-to-end anastomosis of the coarctation. The surprising intraoperative finding was finding an aberrant right subclavian artery, which was preserved and not ligated. And in that case, actually, the surgeon was not happy to make this diagnosis intraoperatively, as he thought that the risk of recurrence in these cases will be higher if you have an aberrant right subclavian artery, and he would rather have done it through a sternotomy to have a higher chance of preserving that right subclavian artery and to have a lower chance of recurrence of coarctation. And coming from an institution where we performed a lot of epicardial echocardiograms in cases with sternotomy, this was actually the first time I see an epicardial echocardiogram from a case with left thoracotomy. So I thought I should share that with you. So in this picture here, this is the site of the anastomosis here, this is the ascending aorta, and this is the descending aorta, and this is the aberrant right subclavian artery here, and you can see here that the anastomosis is widely patent without residual coarctation. Similarly here, this is just another look at the site of the anastomosis here, and you can see that it is widely patent without any coarctation, and you see that the head and neck vessels, which are these blue jets that you will see in just a second here, are also patent without any obstruction. So going to the echocardiogram in Day of Life 0, I think we never saw the branching of the first branch of the aortic arch, and that resulted in this misdiagnosis of a normal arch, and the fact that this patient had a right subclavian artery. It's maybe that red jet that we can see every now and then here, but we were not able to show that in the first postnatal echo. And similarly here, when we are sweeping to see the first branch, we never saw that well enough to call it a normal branching. The arch branching pattern is important in cases with coarctation. So in this recent article from Iowa, they looked at patients with bovine arch anatomy, and it was found to influence the coarctation rate in infants after coarctation repair. So the study included 49 patients with left thoracotomy to repair the aortic arch, and the echo report was reviewed and identified bovine arch in only 3 out of these 49, while if you do direct image review, it was found in 14 out of 49. And this could be due to the fact that we consider bovine arch a normal variant in most other populations, and we tend not to report it. Now, the striking finding from that study is that the recurrence rate was 28% in patients with bovine arch and 5.7% in patients without bovine arch. And the increased risk is likely due to the reduced clampable distance, and that was the hypothesis in that paper, that the surgeon will have less distance to put the clamp on. And the paper also recognized that identifying arch anatomy is important for deciding when to use sternotomy. Similarly, some previous papers reported that there is a higher risk for recurrence for obstruction of LVOT in patients with interrupted aortic arch if they have an aberrant right subclavian artery. And the theory behind that is that if you have an aberrant right subclavian artery, that right subclavian usually arises from the descending aorta distal to the site of the coarctation. So less blood is going through the transverse arch, so the transverse arch may tend to be more hypoplastic, and that may increase the risk of recurrence after coarctation repair. And I think that was the theory of our surgeon as well. Now, regarding the question of sternotomy versus thoracotomy, this study from Cincinnati Children's looked at 102 neonates and infants with lateral thoracotomy for coarctation. The median follow-up rate in this study was 6 years, and the reintervention rate was only 6%. However, they created a score for long-term success, which was found in 63% of patients, so only 63%, and it was defined as a gradient below 20 by echo, a cuff gradient below 15, and no hypertension in this patient population. And the study found that larger distal transverse arch diameter may play a role in the success. It did not reach statistical significance with a p-value of 0.06. However, the hazard ratio was 0.7 with each increase in 1 millimeter in the diameter of the distal transverse arch. What that means is that maybe having a larger distal transverse arch is associated with the success of left thoracotomy, and many surgeons, in cases where the transverse aortic arch is small, will go ahead and do a sternotomy to make sure that they address the hypoplastic transverse arch. So in summary, today we looked at the aortic arch anatomy and branching by echocardiography, which is essential in cases of coarctation of the aorta, and careful identifications of arch branching pattern will help with surgical planning in these cases. Thank you and have a good day.